So 3, 2, 1. Good
Action.
evening, good morning, wherever you are in the world, as per your GPS. But I welcome you all. It's Radiosurgery webinar. For a change, today my co-chair, Dr. Salzuk Packer, is not here. But I welcome today's speaker. And I must tell you, the topic which we have assigned to him is a topic which has not been very favored indication, and not many people were actually confident in treating it with the radiosurgery. And Taiwan Veteran Hospital is one center which championed the stereotactic radiosurgery for dural arteriovenous fistulas. And we have today's speaker, Dr. Huai Che Yang, who is a young and dynamic neurosurgeon. At a young age, he is director of the Department of General Surgery at the Taipei Veteran Hospital. He is also the vice director of the School of Medicine, National Yang Ming Chiao Tung University. We are co-board members and affiliate members of the International Stereotactic Radiosurgery Society. He also holds the post of Secretary of Asian Lexil Gamma Knife Society. He has served as Secretary of Taiwan Stereotactic Radiosurgery Society. His keen interest is actually the radiosurgery of vascular malformations, especially the arteriovenous malformations and dural AV fistulas. Apart from it, he has a wonderful team, and as a wonderful team member and leader, he is looking at the role of artificial intelligence in the radiosurgery. So I welcome Dr. Yang, and I'm very eager and excited to listen to your talk on gamma knife radiosurgery for dural arteriovenous fistulas. Over to you.
Okay, well, first of all, thanks for WNF's invitation, and thanks for the introduction from Manju, my old friends. And today's it's my honors to actually share our experience, more than 20 years treating gamma knife dural AV fistula with gamma knife radiosurgery. So let's go through the first slide. The first introduction about the epidemiology of dural arterial fistula. It accounts for like 5 to 20% of all intracranial vascular malformation, and most occur in the middle age of adults. Not like the cerebrovascular malformations. Most dural arterial fistula was thought to be acquired, but later we will talk about some dural fistula may be accompanied with some congenital vascular anomaly for those complex cases. But for this acquired case, I think a strong associating with the cerebrovascular sinus thrombosis and some hypocoagulated status, head trauma, so private neurosurgery. These are all being reported before. And I believe that the true nidus of this dural fistula is embedded in the dural sinus wall. And the nature of the dural fistula sometimes can be progressive. And I think we all agree that from previous experience, if a patient's dural fistula is combined with a retrograde floor of sinus and the cortical drainage vein engorgement, that may increase the hemorrhage risk of the dural fistula. And also, some patients with aggressive neurological symptoms might need the treatment. And this is all I mentioned about the great pictures shared by Dr. Van Dijk in 2002 in stroke, that the persistent cortical vein reflux in dural fistula may yield a mortality of more than 10.4% per year. And the location of the dural fistula highly depends on where the sinus is. And according to the previous experience, I think the most often common places to have a dural fistula is, first of all, is a cavernous sinus. They account for like 20 to 40% of our dural arteriovenous fistula cases. And the second one is the transverse sigmoid sinus. I think everybody have faced of this kind of cases. And other less common cases, but we're still seeing in some referrals, is from maybe it can be showing on the dural fistula in tentorium, in some place in suprasagittal sinus and anterior fossa, or even in skull base, where the sinus can have this kind of a dural fistula. And for a symptom of the dural fistula, I think the most common one in cavernous sinus, everybody have know that the patient might come to your clinics with a red eye, ecchymosis and some complaint with the blur vision, and few cases maybe complain about a double vision, that which the fistula is aggressively compressed to the cranial nerve to cause this double visions. And also, and on the other hand, in the transverse sigmoid sinus dural fistula, most patients may complain without like pulsatile tinnitus, headache, and sometimes with a severe headache. And if it's in the tentorian dural fistula, the most common symptom we see is like hemorrhage, and the patient might come to the emergency room because the tentorian fistula hemorrhage. And for the superior sagittal sinus, we sometimes see the patient will have a headache. In a few cases, they will complain with the engorged scalp vessel, and also some ICP symptoms if in severe case. In the classification of the non-cavernous sinus dural fistula, I think everyone is well known about like Cocknut classification and Border classification. This is the most common classification we actually to classify those dural fistula. And for instance, like in the Cocknut classification, it's divided to depends on its venous drainage and its floor patterns. And for more benign fistula in Cocknut series is like belongs to type 1 and type 2. They don't have the cortical vein drainage showing up. But for more aggressive, and we call this for high-grade fistula, they all may have the cortical vein drainage and showing a higher risk of bleeding. And this is the chart from the original paper published by Cocknut in 1995, and he clearly demonstrated that how different the low benign dural fistula may present their symptoms compared with the aggressive dural fistula. In the hemorrhage risk and the aggressive symptom risk is all different. And on the other hand, in the cavernous sinus dural fistula, we're using different classification. I think everybody are more common to tell like what is indirect and the direct dural fistula shunting. And in barotype, type A is the most common direct type fistula. So the shunting is directly from the carotid artery to the cavernous sinus. And for all different indirect floor may coming from is for barotype B, C, and D. And so it's coming from, some is from the branch of the ICA, and then C is from the branch of the extracarotid artery. And in D type is the both the branches, is shunting branch may come from both internal and the external carotid artery. So for the treatment of the dural fistula, I think we started with a conservative treatment because something that some series says that in the low risk dural fistula, the low grading one, if the ball is not so high and severe, they might have the chance to spontaneous regressions during observations, and this may happen in 10 to 50% of risk in the series, and most commonly is from the cavernous sinus dural fistula. And I think most of us centers now agree that the endovascular intervention therapy will be the most common choice for the treatment of dural fistula compared with surgery and radiosurgery. And their technique and the material had great improvement in recent years. So they have many different material they can use to stop the shunting from the previous particle, coil, onyx, and they can put it inside to the different stent floor diverters. So, and it can go through from the artery route or venous route. So the improvement of this endovascular intervention therapy actually been dominate to treat in the treatment choice for the dural fistula. So now I think very last patient was being treated to like the surgery and the radiosurgery, and that's why today I'm talking about what kind of the dural fistula and how to treat with radiosurgery, and what's the benefit and from treating those dural fistula with radiosurgery. I'm from big hospitals in Taiwan. I think Manjo have visited our centers. Is one of the largest medical system in Taiwan, located in Taipei. And we started gamma knife treatments in 1993, so it's more than 30 years. We have treated patients with different various kind of indication here in Taiwan. And now we have almost about 600 patients per year's treatment here in our center. And this is a series we published before, and we actually can see that in the dural fistula treatment, just like Manju mentioned, we have a really dominant experience. I think you can see from the total amount chart, and most of the cases is from late 90s to 2010. During that times, especially in Taiwan, a lot of cases were referred to our center, so that we have this kind of chance to treat those patients and publish our result. In recent years, I think it's because the improvement of the neurovascular technique and the more center they can treat this kind of indications. So our patient volume for dural fistula is a little bit dropped, but still we constantly have this kind of patient treated here in our hospital. And this is the first article we published in 2013 to about like Taipei veteran GK experience in dural fistula. During that times, the paper we published, we accumulated like more than 200 of CC fistula and about 86 transverse sigmoid fistula. And the result that the most 94% of the cavernous sinus dural fistula we treated with only radiosurgery only, and for the non-cavernous sinus dural fistula, they have more chance to combine with both surgery and embolizations. But still, like 60% of patients only have undergone radiosurgery. And this is the radiation volume and radiation dose we give. You can see that in cavernous sinus, the marginal mean dose we give is about like 17 gray, and for non-cavernous sinus, it's a little bit lower, but it's still as high as like 17 gray also. And this is a cavernous sinus dural symptoms improvement experience in our centers, and we see that most of the symptoms of the cavernous sinus have been mentioned, like red eye, chemosis, and the protosis, and they can be had a very high improvement rate after radiosurgical treatment, and so the symptoms may have gone in a few months after the radiosurgery treatment. And this is one of the demonstrating of our chart of our gamma knife plan. 63 years old female. He had the right eye redness and pain, and diagnosed with right indirect cavernous sinus dural fistula. And this is our treatments gamma knife radiosurgical plan. And you can see that during the planning, actually, we should actually drawing the out the optic nerve and very closely to let the optic nerve in acceptable tolerant rate of radiation. So in this case, like we only gave like a 16 grays to cover the margin of the cavernous sinus, but the center mean dose is still high and homogeneous. And so you can see that even with the marginal dose only 16 grays, this fistula can be really well operated after 1 year's follow-up. And this is the Kaplan-Meier chart from our cavernous sinus dural fistula experience. You can see that the symptom improvement is mostly earlier than what we can got from the image prove total obliteration. Then this is quite good for patients because patient might suffer from the symptom and it can get earlier symptom recovery, and then we can see that the shunting floor is getting go away, improved by the clinical image. So the patient don't have to suffer too long neurological symptoms. And its typically cure rate in the first year is like 70%, and the second year is maybe 90%. And only very few patients may have the symptom left during the follow-up. And for non-cavernous sinus dural fistula, this is a case we are trying to demonstrate that our gamma knife planning. And this is a 63 years old male who suffered from left ear posictal tinnitus and diagnosed with Cochlear type 2A at B dural fistula. So means that he already have a cortical drainage vein with retrograde sinus flow. And you can see that the dural fistulas actually is very diffuse, embedded in the whole sinus, transverse sinus and sigmoid sinus wall. So that we have to use many shots and closely actually to cover those sinus area. In this case, we use more than 20 shots to cover those area and be careful cautiously not to damage the brain underneath, so that we can focus on actually giving the radiation to the sinus wall and the shunting point, and without damaging the brain. And in this case, we also have a good result that the shunting stop getting decreasing in the 6 months and 12 months. Almost there's no shuntings, and then when the 1.5 years follow-up, you can see the dural fistula was totally gone. And this is another case with transverse sigmoid sinus, which being treated with embolization before 3 times, but still have a shunt residual and recurrence. So they refer this case to our centers, and after giving the radiosurgery treatment, we can see that actually the dural fistula has successfully been treated and successfully operated. And this is a Kaplan-Meier grade for our non-cavernous sinus dural fistula, both in the clinical and image outcomes. And we see that also the same. The symptoms might have recovered earlier than we saw from the image totally operated of the shunting. That means that once the flow of the shunting is slowly gradually going down, patient symptom may already have a chance to become improvement. And once they get the image proof operated, the symptom can totally gone. And this is the whole outcome of our previous published series in 2013, and we think that still in the lower risk cochlear type dural fistula, we can get like almost like 70% observation rate. In more higher risk with the cortical drainage veins engorgement cases, the observation rate may be lower, like to almost 50% of the case can get total operation. Compared with this series published in 2015, they had actually include 19 different series published online that they think that the system review, they also got a very similar outcome from our center. They think that in the complete operation rate for radiosurgery treatment for the cavernous sinus dural fistula is about same like our centers, and also the non-cavernous sinus dural fistula is also get like 58% of the operation rate. And they also found that the radiosurgery maybe have better outcome to treat with the dural fistula without the cortical drainage veins engorgement, means to better outcome in low-grade dural fistula. Okay, so maybe will a question that for the lower grade dural fistula, maybe just if the patient do not have a radiosurgery, if we just observe those patients, patient may still get the chance to spontaneously recover. So maybe we don't have to treat with the radiosurgery. But from this article published in last year in October, actually they prove that even in lower risk dural fistula, if we treat with radiosurgery, actually it's better for them to get the experience symptomatic improvement compared to the observation group. So, and the patient undergone radiosurgery, the complication rate is really low, and lower to 3% of the serious, and most of the symptoms can be resolved during the follow-up period. And there's no difference with the hemorrhage risk. And the conclusion they make is that radiosurgery is a safe and effective upfront treatment alternative for the low-grade dural fistula and compared to the observations. So we can see that the advantage of the radiosurgery for treatment for the dural fistula is that it's a less invasive and procedure compared to surgery and embolization, because the complete circumference, the immediate risk associated with open craniotomy, and we can avoid the complication also from the endovascular embolization. And this is the series actually published from the endovascular team. We still notice if they treated with the cavernous sinus dural fistula, they reported they still may have the chance to get that 10 to 39% of the risk to getting the cranial nerve injury. Although most of the transient, but some patient may lead to permanent cranial injury. But if these cases treated with stereotactic radiosurgery in the cavernous sinus dural fistula, maybe we can actually avoid patients suffer from those kind of complications. And also, in some of the dural fistula may locate in a very difficult location and have an anatomy different approach by endovascular treatment. So because the architecture of the fistula and the location cause it's difficult for the interventionist to actually approach to that fistula, and may have a higher risk of the complication if you using either from arterial route or from venous route. Maybe you're facing different kind of risk to getting patients getting the more complication and injury. For those cases, maybe choosing radiosurgery is easily for us to target those locations without to worry about the anatomic treatures and the tortures of the vessel, and to actually avoid those possible complications made caused by the endovascular treatment. And also, actually, in some cases, if they treat it incompletely by embolization or surgery, radiosurgery is also a great tool for adjuvant therapy, and actually can help patients not to undergo again for the higher risk second treatment and second embolizations for those cases. But either understand all this benefit of the radiosurgery, but what kind of dural fistula is better treated with radiosurgery? We have published this series from our cavernous sinus dural fistula group, compare the patient treated with radiosurgery and the endovascular treatment in our center in 2019. And we found that if we're using more detailedly to recognize the architecture of the cavernous sinus, we actually can divide it to some of the cases as it's better suitable for radiosurgery. Like in this classification of cavernous sinus dural fistula, some fistula actually belongs to proliferal type, means that there's a numerous artery feeder and the border of the cavernous sinus is unable to delineate. And in these cases, actually, they may have more higher risk of endovascular embolization. They may use to have to embolize all the feeders and getting more risk of injury of the nerve inside the cavernous sinus. And in this case, the gamma knife treatment the outcome in our center is much better and with a lower complication rate. And also, this is we published in 2018 in Journal of Neurosurgery, is that in some dural fistula close to skull base, it's like we call it the clival epidural osseous dural fistula. And this kind of dural fistula, because it's located in very close to the bone and skull base, and it technically challenged given the interventional complexity and curiosity of the multiple artery feeding and the drainage vein inside the bone. So like we show it in these cases, a 55 years old woman with a Cognate type 1 clival epidural osseous dural fistula, and he has a tinnitus symptoms. So, and he had the first referral from the interventionist because they said the vascular route is so tortuous that it's not possible for them to treat it safely and without complications. So actually, they refer to our center, and we can treat it with the radiosurgery and targeting the dural fistula very well. So see the good result without actually harm, giving the complication may caused by the endovascular treatment. And this is another series we found that maybe in this kind of anterior cranial skull-based dural fistula is also a good case for the radiosurgery, because same for interventionists, they think that this in the anterior skull-based dural fistula is even more difficult for them to approach and to finding the safe way to actually to operate this these dural fistula. So for radiosurgery, it's easy for targeting, and even we can find a shunting point and to delineate the shunting point, and we even don't have to give a very high dose, and in this part of brain is it really non-harmful to damage the brain parenchyma. We can treat it safely and effectively by radiosurgery. And also some cases, if it's failed to treat after first gamma knife radiosurgery for dural fistula, in our center, we try to repeat the radiosurgery for treat for some residual dural fistula after first treatment. And this is we published in last year that we found that after the second and even third treatment, we can actually increase the operating rate a little bit higher, and the symptom relief rate will be even better than the first treatments. And still, the outcome is better, showing in the lower grade dural fistula, but still had some acceptable improvement in the higher grade dural fistula. And like we demonstrated in these cases, after 2 times radiosurgery, we can still treat the patients successfully and without damage, the causing patients some complications or worry about the radiation injury. So since we know about the advantage, what is the weakness of limitation of radiosurgery? I think the first one is all being well discussed about that, because actually we take times to let this dural fistula go away. So we have the latency period after radiosurgery, and some may argue that if the patient have the risk of bleeding, maybe we will let patient on the still on that kind of risk during this latency period. And the second is that since the dural radiosurgery is not always can successfully operate the dural fistula, so some patients may need repeat alternative intervention by to treat the residual part of the fistula. And also, if some criticize may argue that using radiations to treating the dural fistula may causing some radiation-induced complications, and the risk may cause some late onset brain edema, cyst, or permanent neurological deficit. This all have been well discussed in the previous series, but from our experience, we think that this kind of latency period maybe not a totally weakness of the radiosurgery, because I will show you some complex case. Maybe this kind of a slow, gradually change of the fistula after radiosurgery may be an advantage or a better way for the dural fistula to go away, because the gradual operation of the dural fistula after surgery is actually, we can avoid the immediate risk of the aggravated venous hypertension that sometimes flow upright and the structure close. And also the radiation induced completion is very cell fuse shown in our cases, because I think those radiation-induced completion may happen in, like, if you are not treated the fistula very precisely and using the right dose. So like this case is referred from other center. Actually, this female treated with conventional radiotherapy and by one fraction in 2013, and he's keep having the frequent headache and vertigo after treatment. And we saw this image. It had a severe swelling because the very non-precise treatment of the fistula. So it's actually causing the permanent damage of the brain. So patient has to use a steroid to control its symptom and causing some side effect. So when she come to my clinics, and the worst image outcome that we saw from their follow-up page, the image, and actually you can see that the radiation complication might cause this kind of encapsulated hematomas and had this severe permanent brain edema that we have to actually operate to take it out, to stop this kind of vicious cycles, and to stop this kind of severe brain swelling, just because they're using the wrong machine and wrong dose to treat the dural fistula. So it's still have to be very cautious to treat those lesions with well-targeted and precise strategy. Okay, so after we sharing our series, maybe you were asking like when and why we choose the gamma knife to treat dural fistula. I think I should trace back to what I learned from my first training center. I was in University of Pittsburgh in 2010, and during that time, I think University of Pittsburgh is one of the first few centers. They're starting to treat dural fistula with radiosurgery, and I follow the step of Dr. Lunsford, and we actually using the data from the University of Pittsburgh, and I published the data with Dr. Lunsford in 2010 in neurosurgery. And I think during that times, we give a strategy and the management of the dural fistula in this article, based on the experience of University of Pittsburgh. And during that time, we agree that patients should go through the angiogram and to divide it to like low risk bleeding risk dural fistula and high bleeding risk dural fistula. And if patient with the is no symptoms or very trivial symptom, maybe you can observe it. And if the patient have more aggressive or more severe symptoms, we can first evaluate the embolization vascular access, and with the poor vascular access, maybe we'll try to do the radiosurgery. But with the good vascular access, maybe embolization first and or alone, and then consider radiosurgery. But if the high risk bleeding risk dural fistula, during that time in Pittsburgh, they all still recommend embolization first and then treat the radiosurgery with the residual or recurrent lesion and follow the patient regularly. But this is the concept during like 20 years, 10 years, 15 years ago. And I just saw they publish this article from the group of University of Pittsburgh in this May. And actually, I think the radiosurgery actually had to be involved during this 10 and 20 years. So we were slowly changing the concept, like things that if now the image technique been improving or not, and also we had a better machine and more precise treatment technique. And so you can see in this article, they are thinking that this might be giving the more conformal dose of delivery and minimize the brain irritation, and so expanding our treatment indication to some of the even high-grade dural fistula. So I think this is because the treatment technique improving in the recent years, so that we can also get a better result to treat the higher risk dural fistula and make it become even in some difficult case. So I think we agree with this kind of a trending change in recent year, not only in our hospital, but they found this kind of a trend in University of Pittsburgh. Okay. In the last part of my talk, I want to share some of what we thought is a very complex and a complicated, difficult case treated in our center and what we learned from the treatment experience. Some is failure, some successful with this kind of a case, and what can we learn from this case? This is the first case I wanted to share with us, and this is not a successful case, but we learned something from this case. This is an 80-year-old male. He came to our emergency room with sudden onset headache, are still very clear, but a little bit drowsy and a severe headache. And from the brain image, we saw that they have the intracranial hemorrhage, and the angiogram and the MRI image we performed, we proved that this hemorrhage is caused by his high aggressive dural fistula. And you can see that in this angiogram of this gentleman, he had very poor venous drainage system. They had the fistula in one side, and the other side had a very narrowing transverse sinus system. So means that these patients have very poor venous drainage system. So he is under a kind of risk that we are not expected. So in this cases, actually, during that time, we treated with only embolizations, and we try to actually operate the fistula. It sounds very reasonable because there's ICH might caused by this dural fistula. So maybe we should stop this kind of risk to actually operate the dural fistula right away, because this is a high-grade floor dural fistula causing this intracranial bleeding. And actually, it's a very successful embolizations. I would say that you can see that after embolization, the angiogram they do right after the procedure, the dural fistula was gone, and they still check the venous system is okay. But this patient actually did not have a very good outcome. Her conscience didn't coming back, and even getting more drowsier, and the pupil dilate right after the embolization, and we're showing there the diffuse SDH and SH showing on the brain image. And this patient actually passed away in a few days, but later we will discuss why this is a failure case to treat the dural fistula by only embolization. Okay, let me show you the second case. Second case, this is a 20-year-old boy, a young adult. His head was hit by a baseball a few years ago. And since then, he had a pulsatile headache, imbalance under static gait, and found they had a trauma-induced transverse sigmoid dural fistula. And unfortunately, before he came to our clinics, he already undergone 10 times transfer embolization. So they had a very astonishing image when he came to our clinics. We see almost a big iron ball was showing in his X-ray, and see that it's all the result from different times of embolization. But why they have to undergo so many times embolization? Because his hip fistulas keep coming back. Once you thought you already cured the fistula, but the fistula were growing back and having new fistula to growing just adjacent to the previous embolization site. So we try to to treat this patient with radiosurgery, and you can see that in the image right side, initially it seems like has some response. The dural fistula has limited, had a lower floor and going on, but a few months later, again, the new fistula coming back, and you are almost is chasing the new fistula after every time the treatment. And this tragic case, actually, he had also had very bad outcomes, and he passed away after so many times of different treatment. And so later we can discuss why he's having this. And this is the third case we want to demonstrate us also. It's a 41 years old woman who suffered also from only right side ear pulsatile tinnitus and sometimes blurred visions. And so he had both ear and eye symptoms. And from angio point of view, he actually have a transverse sigmoid sinus congnat type 2FB. But very similar to the first case, you can see that he's bilaterally transverse sigmoid sinus drainage system has some occlusion, and it's not a very patent venous drainage system. So when we treat it with radiosurgery, and again, we can actually have this dural fistula being treated and total operatorly, but we also, you can see that the venous drainage system become even worse. And after our treatment, so patients, although the dural fistula was regressing and almost gone, but clinically, the patient actually had some deterioration of his symptom, and his not only his tinnitus not going away, but his blurred vision is getting worsened. So what we learned actually from these very complex cases, when we think that, so like this kind of a complex and complicated dural fistula, this may have a more aggressive behavior and intractable to what we thought can treated by a single treatment management, either by embolization or by radiosurgery. So the possible feature of this complex or complicated dural fistula is the patient might have some damage showing they have like multiple dural fistula, and not only have a shunting point in a single locations, or patient may have a poor normal sinus drainage system, not only bilateral transverse sinus system is nearly occlusion, or sometimes it's directly occluded in the superior sinus system. And also, patients maybe sometimes show more severe and diffuse cortical vein drainage system with venous congestion. You should be aware of this kind of sign before you treat the patient, or patient come to your clinics, had already undergone several times different kind of treatment for his fistula, but still failure. So we call it repeat recurrent dural fistula. These are the sign and possible feature of maybe this kind of fistula is not very simple, and he had many unknown etiologies underneath this dural fistula. And our team, actually from our neurointerventionist, he published this. I think this is kind of an important article. We demonstrate how important is the venous outflow restriction may affect patients' hemorrhage and symptom outcome in 2007 in radiologies. We actually, during that time, this is a retrospective review from our series from 1995 to 2016. And he actually evaluate the venous sinus patency by the score we actually create. And this is we call it outflow restriction score, which if the patient has a fistula, maybe we can actually divide it to the distal end and the proximal end, maybe left side or right side, and we can calculate the patency of the venous drainage system. If it is totally occluded, maybe he can get only 0 point, and if it's less than 25% of stenosis patient get 4 point. And we found that in all of our cases, if the patency score is lower than 2, means that bilaterally, not only distal, but also proximal end of this dural fistula has a problem. So it means that the venous outflow is very restricted. Then you may increasing the risk of a patient having more aggressive neurologic symptoms and may have a higher hemorrhage risk after during his having this kind of a dural fistula. So it's even more sensitive than we actually notice the patient if have the cortical drainage engorgement or not. So this is a kind of interesting finding that we saw how important actually the venous drainage pattern will affect the treatment and the patient's symptoms after dural fistula. So after we learning from these cases, we think that the etiology of this kind of complex dural fistula formation might be very different from what we usually think the simple cause of the dural fistula. These patients actually might have some coagulopathy caused by multivessel thrombosis, and this thrombosis may causing he had a more active neogenesis of the vessel to recruiting some new vessels even after you try to stop some of the fistula by any treatment option. And the reason they have to create those vessels is maybe it's because the basic venous outflow obstruction and this venous drainage floor is already been restricted, so they have to regenerate those kind of dural fistula to actually drain his normal blood flow out of the brain. Or had any unknown factors, we still searching for. We maybe have to be very careful to survey those patients. And so these unpredictable floor change after the treatment can cause some problem, because if you actually close those kind of shunting, if this shunting is actually a very important functioning floor for the patient to actually drain his venous blood flow outside of the brain, you may actually close the most important door for this patient. So that's why those patients, after closing those functional dural fistula floor, patient may have a very devastating and acute symptom deteriorations after the treatment. So if we have to be watch out to see if this kind of fistula is very important for these kind of difficult cases. Actually important for them to giving their venous drainage changing after those unknown venous restrictions. Okay, so to treat this kind of patient, like what we demonstrated those tragic case, maybe we have to be careful to evaluate this kind of venous drainage pattern and to decide which dural fistula actually we can treat safely. And so this is why I told that for compared to embolization, gamma knife and those radiosurgery actually given the latency periods for the patient actually to adapt the floor. And because for embolization, for the interventionalist, if they actually shut down the floor too fast, patient may don't have this kind of timing for them to adapt the new floor. So that's why in these cases, although gamma knife or radiosurgery may be not a way that can only to successfully treat those floor, but he actually compared to embolization, he giving the lower complication rate right away happen for the endovascular treatment. So for these kind of complex case, gamma knife actually the latency period is a good thing for the patient to adapt the floor and to slowly adjust their self to for the new environment. Actually, shunting is been closing. So Okay, so now in our center, for facing this kind of complex dural fistula, we actually have to need more to understand the etiology why this patient have this kind of dural fistula shunting, and we try to just stop this kind of vicious cycle, but not only just stop to close those shunting, because those shunting sometimes might be very important drainage output for those patients. So we try to treat these patients with combine different strategy and try to guide the blood flow to the right way. So sometimes we need to combine treatment with cooperate with the interventionist. Like some patient may need a venous angioplasty to reduce the venous pressure first and decrease the venous reflux. And also we maybe need some stent in the dural sinus to restore and reconstruction the venous channel and outlet first, and then restore the normal physiology drainage system for those patients. And the radiosurgery play an important role also because we give more time for those patients to self-adaptation the fistula operation after the treatment. And in this case, sometimes we also consult our neurology to see if they had this patient needs to take some anticoagulation therapy during this follow-up period to avoid some severe and too fast the flow change during the follow-up period of these patients. Like this case, 60 years female had more than 10 years had headache and had aggressive, aggravated engorged vessel. That's why I saw had more aggressive cortical veins seated all over his head. And in this case, we see that he had a very restricting floor in his sagittal sinus part. So we not treat the fistula right away, but we try to restore his sagittal sinus floor, and we putting a angioplasty to actually to normalize his sagittal sinus floor, and then we try to treat the gamma knife after this kind of procedure. And we can see that after this kind of a combined treatment, patient can get better outcomes during the follow-up without having a severe complication or problems. And this is another case, a similar case from we treated failure before, and he came to our service with left ear tinnitus, and both sides have the blurred vision and red eye. So he again have both ears and eye symptoms, and also have memory declines. And so we think that this dural fistula with type 2 and A dural fistula of the left side transverse sigmoid sinus has been combined with the patient with have some occluding sinus disorders. So you can see this is been proven by the image that both sides of the transverse sigmoid system is not very good. So in this case, actually we put a stent in the transverse sinus first to actually give the patient have more venous outflow opportunities after the treatment, so we don't actually closing the shunt too rapidly. So we can see that before the stent, we put the shunting. Actually, it's different. See, this is a pre-stent, and this is a post-stent. So you can see that after stent putting the bilaterally transverse sigmoid venous drainage is improving. And this, after we actually normalize these venous drainage symptoms, we start to treat the fistula and without concerning about his rapidly symptom deterioration. Okay, so we go to our take-home message for today's talk. I think radiosurgery also already been proved to be a highly effective and safe treatment. Although it's not a main treating option now for dural fistula, but it's definitely an option to treat the dural fistula in not only low risk dural fistula, but also high risk for sometimes. The non-invasive advantage avoid immediate risk of compared to the surgery and the endovascular treatment, and the success rate is quite high. Although compared to embolization in some simple case, maybe we take times to actually not to closing the shunt right away, but after a few months to years follow-up, we can still got the dural fistula closed successfully. And so it's very suitable for those dural fistula. Is anatomically things is difficult for the interventionist to approach by endovascular treatment or by surgeons. And those cases actually can be tackled beautifully by radiosurgery, and we can plan it and follow other patients in a much more lower complication rate and lower symptom deterioration rate. And the latency patient, as I say, is maybe a double-edged sword. Although it actually give the patient maybe have some more risk of a bleeding, but this kind of latency period actually allow the brain have the time to hemodynamic adapt and avoid the immediate risk of some severe venous hypertension that sometimes happen if the shunt closed too rapidly by the surgery or by embolizations. And the third take-home message is that when we use the radiosurgery, is recommendable for some symptom or lower symptom cases because we have a high operating rate, and so we don't have to worry about the complications sometimes caused by the embolizations. So we can, if you select the very specific right patients, radiosurgery maybe is a safer treatment choice for those patients. And it's also served as a adjuvant therapy for those patients fail to have the first embolizations or fail to by the surgery. So even fail by the radiosurgery, we can try to treat it second time and get a higher successful rate with low complication rate or radiation injury rate, because radiosurgery, if you get it in the right and the precisely way, we have a very low risk to damage the surrounding brain area and causing new problems. So but in some complex case that I have shared our experience, you have to very watch out the venous outflow, and you can using our score system to evaluate the patient's venous outflow to see if they actually under the risk of very the devastating change may happen after the treatment, or you can evaluate very closely by the integral architectures. And treating these kind of dural fistula with the poor sinus drainage system, you have to combine the solution, but not just closing the shunt right away. And sometimes we have to restore the normal pathway and to restore the venous first, and then consider to shut down those shunting after having the patient in a safe venous drain pattern. Okay, so I think this is what I want to share about our more than 20 years treatment experience to treat the dural fistula, and we're now sitting in Taipei City, so it's welcome everyone. If you have a chance, we can discuss either in the future in the meetings or later in the discussion. Thank you.
Thank you, Dr. Yang. First of all, you should accept my congratulations, because not many centers in the world, even the busiest centers in the world, do not have this vast experience on dural arteriovenous fistulas. Even as I told, even my experience is limited to a single digit, though we treat so many patients. So, and with your talk, what I could understand is that it's not only the disease, it's the philosophy actually. And this philosophy evolved even at your center once you had an option of endovascular embolization. So earlier you were treating practically everything with radiosurgery, and now you have moved to a combined approach, and philosophy has developed in the terms of etiology or scoring systems, looking at the sinus occlusion, and yes, with a couple of failures too. If I ask you my question, if I may ask you, treating an AVM versus treating a fistula, it makes a difference. The first question which comes to my mind, in AVM, we are sure this is a nidus. We go with a DSA, we go with an MRI, we have very specific sequences, and then we find that, okay, this is the nidus, and we are very confident in treating it. But in dural AVF, we do not find that specific sort of a radiological appearance where we can say that this is the part. So how to define a fistula for radiosurgical targeting?
Yeah. Yeah. Thank you for your questions. Yeah, I think this is a challenge actually. If you try to treat every dural fistula, some dural fistula is very straightforward. You just have a very clearly shunting point from the angiotextures, and if you actually know where's the single shunting point, that is the point actually you have to you can successfully close it. And this is the same philosophy by what they treated with endovascular treatment. But like I said, especially in like on some transverse sigmoid sinus fistula, we often see that there's a long part of transverse sigmoiditis. You can see that it's showing the brightness in time of flight image in MRI. And if you combine the angiotexture, you can see that there are a lot of small shunting actually go along the sinus wall, so that causing this kind of fistula hard to treat either by the interventionists, because if they wanted to close those shunting, sometimes they have to sacrifice the whole transverse sigmoid sinus in unilaterally, and that might be a very dangerous things to actually to just close the normal venous venous drainage pattern. So for us, actually, that I said, we not only like actually targeting the first in the MRI and you drawing the whole possible shunting points with the bright area that is showing up in the MRI. We also to actually see the image from the angiogram to make sure that all the different fistula pathway has been covered by our radiation field. So you sometimes you can see after drawing the target volume is actually very narrowing and tortuous. It's just alongside of the transverse sinus. And you might question that, well, you actually same like embolization, you treat the whole part of the sinus by radiosurgery. But from our experience, if you give like the marginal dose, like to lower like to 16 to 18 gray marginal dose, those sinus still preserve. I think this is most importantly. Even you treat it with the radiosurgery, you still preserve the normal sinus functions after our long-term follow-up, because radiosurgery will not damage the lumen inside, but also it had more effect to the side wall, and actually so that we can actually close the dural fistula slowly and follow it by time, but preserving the venous outflow. And I think this is what we learned from our treatment strategy and the planning. Yeah.
I see that your marginal dose is relatively less in comparison to what we prescribe for an AVM. In AVM, we
Yeah.
usually go more than 22, 23 gray. But in your series, what I could see, it's even close to around 16 gray or 17 gray, which you have been treating it. So has this dose reduced historically, because you could see that even with the lesser dose, we are able to achieve that good outcome? Or were you always with the lesser dose from the very beginning? What's the rationale behind that?
Well, initially we like to treat giving the marginal dose like up to like same like AVM, because it's also the vascular lesions. We try to like if we can give it safely, we would love to give like to 18 to 20 grays as a margin growth, like just like we treating AVM. However, because that I said, sometimes the after withdrawing the whole sinus point, we saw that it's covering a large area, and that's make our we have to concern if we give in that kind of high radiant marginal dose, maybe the surrounding brain tissue may have too much radiation coverage, maybe cause some permanent brain injury. So that we initially we think, okay, maybe we sacrifice a little bit marginal dose to like 16 to like 17 grades, and we think that in these kinds of case, they still work. Yeah, the shunts can still successfully operated even if we lower down the marginal dose till, I think, at least 16 gray. So this is from our point of experience. So if you are very hesitant to treat a too large area of a shunting point of a dural fistula, maybe the marginal dose till like the 16 gray, it still can get a good outcome, a higher chance for the fistula to actually successfully treat it. Yeah.
In your couple of last cases, you showed combining with the stenting. So whenever we usually stent, we administer anticoagulants to these patients for close to around at least for 6 months. So do you practice that same in your case, and does it increase the chances of hemorrhagic complications in the interval period?
Well, I have a case that just the same case I demonstrate that patient putting this stent. He actually using the anticoagulate longer, not more than 6 months, and he had in this case he had one times have a small cerebral hemorrhage, but with not so many severe symptoms. So we actually stopped the medication for a period, but still asked him to add back after we saw it safe and judged by the neurologist. Because we think if the stent is being up, if he didn't take the medications and the stent become occluded, because he stopped the medication, maybe this case will have the recurrent symptoms coming back. So we still very closely monitor his coagulation function, but still ask him to take the medication if possible. But this is the only case I experienced have some hemorrhage complication after taking anticoagulant therapy. But rest of the case, I think we at least have like maybe 10 to 12 cases having this shunt and also treat with dural fistula, they still now under good follow-up without finding hemorrhage or something. But it has to be closely monitoring. That's the truth we actually need to follow up. Yeah.
There is one question which Dr. Gaurav Tyagi, who is a ZAP user, he has asked that what are the nuances for the target contouring, especially in post-embolization complex dural AVF? So before you answer this question, I would like to ask you how much time interval do you keep between embolization and adjuvant radiosurgery? Or what's the sequence in which you would like to do that?
Yeah. If you go to find my article published in Pittsburgh, in that 2010 article, Dr. Lunsford had one discussion point. He said, if you need to actually treat a dural fistula combined with embolization, in Pittsburgh experience, he suggests treat the radiosurgical first, surgery first, and then embolization, because sometimes after embolization, he will mask the fistula right away, and it's not good for to denerate the whole sinus. So from Pittsburgh's experience, he suggests if it's possible, you are planning to have combined treatments, he suggests you treat the whole sinus first, whole shunting point first, and then embolizations. But sometimes we got referral from residual or recurrence, and the patient already had embolizations. For us, I will not, if it's possible, we not wanted to treat the patient right away, because patients even right after the shunting, his fistula still had time to adapt the new situation after this kind of treatments. So we have to follow up to see what happened after they close those partially closed dural fistula, and to see what is the whole picture of the dural fistula. So if I can follow this patient, I would suggest at least follow the embolization to see what is changed at least 6 months after the embolizations, so that you can see the whole picture of the dural fistula, but not being masked by the immediate response by the embolization. Sometimes it can be partially being missed, but there's some bias inside. Yeah. So I think 6 months is my suggestion, but it depends on what your every case's situations. Yeah.
What's your policy of following these patients radiologically? Do these patients always get a follow-up DSA, or you are good with certain MR images?
We suggest patient at least follow MR at every 6 months after the treatments, and once we started is getting the operations, and we didn't see anything in MRI. Personally I would suggest patients to still have the angiogram, because angiograms is still the gold standard to prove that there's no shunting, because some very tiny or slow flow shunting, you can see nothing in MRI, but still seeing in angiogram. So I would suggest every patient still have angiogram. But since it's an invasive procedure, some patients, their symptom gone away, they were said, oh, okay, I don't want to undergo this invasive procedure, but I choose like still coming back for the follow up, like with even after the fistula is proven, operated by MRI, maybe 2 or 3 years, again to come back to make sure that no fistula is recurrent and no symptoms coming back. So I would say in our center now, maybe 60 to 70% patient will have the angiogram, but the 1/3 of patient, they will choose not having the procedure to just confirm the dural fistula was gone. Yeah.
Interesting. I think it's we have already overshooted the time, but I have one more question. If there is no other question from the audience, because you showed a very interesting series of your clival osseous dural arteriovenous fistulas. So I wish to know, how did they present, and did you include the bone in your target while treating those patients radiosurgically?
Yeah, we included the bone. I think bone is safely to treat it. If the radiation cover the bone we can see that we treated in some skull-based tumors or some skull. The bone actually is not that is tolerable for surgery radiation coverage, and but you have to watch out if some cranial nerve is passing the skull bones in some canals, and if you should closely follow up those cranial nerve, but not the bone. So I think bone is not the issue, but the cranial nerve path through the bone should be carefully being delineated, and to watch out the dose. And for these patients, I think most of them are some is incidentally finding, and some of them have some headache. And but also we have some cases because in the skull-base area, we still have some tinnitus, and patients may suffering from. So there has various kind of symptoms may have happened in this kind of skull-base dural fistula. Yeah.
Since you brought the issue of nerves here, you have treated a lot of these cavernous sinus fistulas. So did you find any cranial neuropathy after radiosurgery in any of your patients?
Yeah, well, we the new developed cranial deficit after radiation, the cavernous sinus is really low. I think only maybe 1 or 2 cases they don't have the cranial nerve symptom, but having the new onset symptom after our treatment. So the percentage I think is lower than 2%. But so I think in the cavernous sinus, the cranial nerve is not that kind of so vulnerable compared to the optic nerve. So I think because it's always almost impossible actually to draw every cranial nerve inside the cavernous sinus when you treat this kind of lesion. But from our experience, we can tell you that even you treat the whole sinus with that kind of dose, we are very seldom have patients have newly onset cranial nerve injury. Yeah.
Thank you. Thank you so much. I have a couple of more
Mm,
questions, but I think the time is running up, so
mhm,
I'll have to catch you up again. And if
mhm.
there is no other question from the audience, I would like to thank you again for this wonderful talk. I really enjoyed this talk. It's
Thank you.
to listen to your experience, and radiosurgery still has a role once the embolization devices have become more nuanced, but still there is something which
Mm,
radiosurgery can offer. And
mhm,
after being so advanced, Taiwan is still treating close to around 25 patients per year, which I could see in their statistics with the radiosurgery, and that shows the value of this technique.
mhm.
Thank you so much, Dr. Yang. Thank you all the attendees
Okay.
for attending this
Mhm.
talk. And soon you will find the next talk, the declaration on the LinkedIn and on your the social media chat. So kindly join again for the next WFNS Radiosurgery webinar, and that is by Dr. Golanov on SRS for craniopharyngioma, again a really controversial topic. Thank you so much again, and have a good day. Good
Okay.
night.
Thank you. Thank you, everyone. Good
Thank you.
night.
Good night. Bye.